Which of the following are risk factors for sudden cardiac death in hypertrophic cardiomyopathy? A. Family history of one or more HCM-related sudden cardiac deaths. B. Massive left ventricular hypertrophy, thickness of 30 millimeters or more. C. One or more episodes of recent syncope. D. All of the above. Correct answer D. All of the above. In addition, non-sustained ventricular tachycardia noted on several occasions and hypotensive or attenuated blood pressure response during exercise are also thought to be important risk factors. It is needless to say that a previous episode of resuscitated ventricular fibrillation or sustained ventricular tachycardia is the strongest risk factor for a recurrent episode. Other potential factors are scars of alcohol septal ablation, apical aneurysm, end-stage disease, and delayed myocardial contrast enhancement seen on cardiac magnetic resonance imaging. Recommended INR value for mechanical prosthesis at mitral position: A. 1 to 2, B. 1.5 to 2.5, C. 2 to 3, D. 2.5 to 3.5. Correct answer D. 2.5 to 3.5. Mechanical prosthesis at mitral position has higher chance of thrombosis than one at aortic position due to the lower pressure gradient across it. Hence, the recommended value of INR for a mitral prosthesis is 2.5 to 3.5, while it is only 2 to 3 for an aortic prosthesis. Low-dose aspirin is also often added along with warfarin in case of metallic mitral prosthesis to reduce the chance of thromboembolic complications. IVC plethora is seen in all of the following except A. Acute left ventricular failure, B. Chronic right heart failure, C. Cardiac tamponade, D. Constrictive pericarditis. Correct answer A. Acute left ventricular failure. Plethora of inferior vena cava is lack of the normal inspiratory collapse of the IVC on echocardiography. Normally, the IVC diameter decreases about 50% during inspiration. Prosthetic valve thrombosis is most likely at A. Aortic position, B. Mitral position, C. Tricuspid position, D. Pulmonary position. Correct answer C. Tricuspid position. Prosthetic valve thrombosis is most likely to occur at tricuspid position because the pressure gradient across that valve is the least. But mechanical prosthetic valves are seldom used in tricuspid position, where bioprosthesis is preferred because of lower thrombogenicity and lesser degeneration at this position. Being much more in use, among cases of prosthetic valve thrombosis, most cases will be of mitral prosthetic valve thrombosis, where the pressure gradient is less than across one at aortic position. Which of the following is not a feature of left atrial overload on the ECG? A. Wide-notched P waves in lead 2, B. Prominent negative component of P wave in V1, C. Tall peak P waves in V1, D. Area of negative component of P wave in V1 of more than 1 Ashman unit. Correct answer C. Tall peak P waves in V1. Tall initial component of P wave in V1 would indicate right atrial enlargement. Uni-component peak P waves in V1 could also be due to an abnormal atrial rhythm. Ashman unit is the area corresponding to 1 small square or 1 square millimeter in a standard ECG taken with a paper speed of 25 millimeters per second and standardization of 1 centimeter to a millivolt. It will be expressed as 0.004 millivolt second. P tricuspidale is A. Tall P waves in V1, B. Tall P waves in lead 2 with initial peak taller than second peak, C. Tall P waves in lead 2 with second peak taller than first peak, D. Tall P waves in lead 2. Correct answer B. Tall P waves in lead 2 with initial peak taller than second peak. The original description of P tricuspidale was by Zuckerman in 1952. The pattern is a mirror image of P mitral in which the second peak is taller. P tricuspidale was noted by Gamboa and associates in 81% of their 37 patients with tricuspid atresia, while it was seen in only 2 of their 20 patients with pulmonary atresia. False statement regarding A and V waves in atrial pressure tracing. A. Right atrial A wave is taller than V wave. B. Left atrial V wave is taller than A wave. C. In atrial septal defect, A and V waves are equal. D. None of the above. Correct answer D. None of the above. Normally, A wave is taller in the right atrium and V wave is taller in the left atrium. In atrial septal defect, A and V waves are equal due to equalization of atrial pressures by the large unrestricted communication. What is the rhythm? A. Sinus rhythm. B. Low atrial rhythm. C. Idioventricular rhythm. D. None of the above. Correct answer B. Low atrial rhythm. ECG showing P waves in inferior leads 2, 3 and AVF. A superior P wave axis means that the atrial activation is proceeding from below upwards. This occurs when the focus is in the low atrium, low atrial rhythm or coronary sinus rhythm. In addition, the ECG also shows an intraventricular conduction defect in the form of notched R wave in lead 2 and AVF and an RSR prime pattern in lead 3. Sometimes this pattern occurs in atrial septal defect and is known as crochetage sign. The QRS width seems to be a little more than that in usual crochetage sign. Low atrial rhythm can occur in sinus venosus AST as the region of the sinus node is defective and an ectopic atrial focus takes over. Gene responsible for familial WPW syndrome. A. KCNJ5, B. HERG, C. PRKAG2, D. None of the above. Correct answer C. PRKAG2. WPW syndrome is characterized by short PR interval, delta wave due to ventricular pre-excitation and consequent arrhythmias. About 3% of WPW syndrome can have a familial occurrence. These familial cases have an autosomal dominant mode of inheritance. The gene which encodes for AMP activated protein kinase was identified as the causal gene PRKAG2. Specifically, it encodes for the gamma 2 subunit, which is a non-catalytic subunit of AMPK. These were missense mutations in which a single nucleotide is substituted by another one, inducing a change of a single amino acid in the sequence of the final protein, which is produced by the action of the gene. Most common cardiac anomaly in Ellis-Van Creveld syndrome. A. Ventricular septal defect. B. Patent ductus arteriosus. C. Single atrium. D. Single ventricle. Correct answer C. Single atrium. Single atrium is seen in 40 to 60% cases of Ellis-Van Creveld syndrome. Other cardiac defects like those of mitral and tricuspid valve, patent ductus arteriosus, ventricular septal defect, and even hypoplastic left heart syndrome have been described. Mutations in two genes, EVC and EVC2, situated on the same chromosome, have been documented in Ellis-Van Creveld syndrome. It is an autosomal recessive disorder. Other features are short stature and polydactyly. Preferred add-on therapy in heart failure to ACE inhibitors and beta blockers. A. Angiotensin receptor blocker. B. Mineralocorticoid antagonist. C. Renin antagonist. D. None of the above. Correct answer B. Mineralocorticoid antagonist. Mineralocorticoid antagonist like spironolactone or eplerenone is the add-on therapy in heart failure to angiotensin converting enzyme inhibitors and beta blockers in the management of heart failure. Spironolactone has been shown to reduce myocardial fibrosis and corrected QT interval. Which of the following beta blocker in heart failure had no benefit? A. Carvedilol, B. Metoprolol extended release, C. Nebuvolol, D. Bucindolol. Correct answer D. Bucindolol. Bucindolol is a beta blocker with partial agonist activity which did not reduce mortality in heart failure trial. Asystole is not seen in type dash of neurocardiogenic syncope. A. Type 1, B. Type 2A, C. Type 2B, D. None of the above. Correct answer B. Type 2A. Heart rate and blood pressure response to head-up tilt test in neurocardiogenic syncope has been classified by Sutton et al. Most common is the mixed type, in which there is a fall in both heart rate and blood pressure. Fall in blood pressure precedes the fall in heart rate, which falls at the onset of syncope. It can fall below 40 per minute and can be associated with asystole more than 3 seconds, though these cutoff points may not be present always. In cardioinhibitory type, there is a fall in heart rate. In type 2A, there is no asystole, but heart rate falls below 40 per minute and remains so for over 10 seconds without any asystole of more than 3 seconds. In cardioinhibitory type 2B, there is asystole of more than 3 seconds. In vasodepressor type, heart rate does not fall more than 10% from its peak at the onset of syncope. Two exceptions which have been described being chronotropic incompetence and postural orthostatic tachycardia syndrome. In the former, there is no increase in heart rate during the tilt test, or any little increase being less than 10% of the pre-tilt heart rate. In POTS, on the other hand, there is an increase in heart rate more than 28 beats per minute compared to the pre-tilt heart rate, which is maintained throughout the duration of the tilt. Plastic bronchitis is seen after A. AST repair, B. Arterial switch, C. Fontan repair, D. VST closure. Correct answer C. Fontan repair. Plastic bronchitis is characterized by marked obstruction of the large airways due to the formation of bronchial casts with rubber-like consistency. Elevated central venous pressure leading to endobronchial lymph leakage is thought to be the mechanism of plastic bronchitis in post-Fontan state. Plastic bronchitis can occur in those without heart disease as well. In those cases due to inflammatory lung disease, the casts are cellular, type 1 casts, while in those with underlying heart disease, the casts are acellular, type 2 casts. Plastic bronchitis has been described after other cardiac surgeries as well. Giant coronary aneurysms are seen in A. Cardiac syndrome, B. Ellis-Van Creveld syndrome, C. Kawasaki disease, D. None of the above. Correct answer C. Kawasaki disease. Kawasaki disease is a rare disorder in which coronary aneurysms can occur in young children. Kawasaki disease is also known as mucocutaneous lymph node syndrome. It typically occurs as a febrile illness with involvement of the lips and tongue. There is conjunctival congestion as well as involvement of the lymph nodes, usually in the neck. Redness of palms and feet and peeling of skin may occur as the cutaneous manifestations. Angiotensin II receptor 1 is involved in A. Vasoconstriction, B. Proliferation, C. Aldosterone secretion, D. All of the above. Correct answer D. All of the above. Angiotensin II is one of the most potent vasoconstrictors. It is also involved in the stimulation of aldosterone release from the zona glomerulosa of the adrenal cortex. Angiotensin receptors are G protein coupled receptors. The important angiotensin receptors described are 81, 82, 83 and 84. Fallacies of assessing mitral valve area by planimetry. A. Inability to get a cut at the tip of the funnel. B. Inability to get a cut parallel to the orifice. C. Inability to get a full circle at the right time of the cardiac cycle. D. All of the above. Correct answer D. All of the above. Mitral valve is often measured by planimetry to assess the severity of mitral stenosis. Usual method is to get a good parasternal short axis image of the mitral valve and measure the valve area using the electronic caliper in the echocardiograph. Once you trace the outline of the valve area is automatically calculated and displayed by the computer program in the echocardiograph. Minimum gradient required for diagnosis of tricuspid stenosis. A. 2 mm of mercury, B. 4 mm of mercury, C. 6 mm of mercury, D. 8 mm of mercury. Correct answer A. 2 millimeters of mercury. The minimum transvalvular gradient required for significant tricuspid stenosis is 2 millimeters of mercury. Cardiac catheterization derived pullback gradient may not be superior to Doppler echocardiography derived gradient, as cath gradient ideally requires simultaneous right atrial and right ventricular tracings. The right atrial pressures fluctuate widely with respiration. So, in order to measure a small difference between right atrial pressure and right ventricular diastolic pressure, simultaneous tracings would be ideal. Though the measurement of right ventricular pressure requires a catheter across the tricuspid valve, the resultant decrease in tricuspid valve orifice may not be that significant as in the case of aortic valve because of the relatively larger orifice of the tricuspid valve. Tricuspid valve is the largest of the 4 cardiac valves. The pressure gradient in tricuspid stenosis is not as high as in mitral stenosis because the right-sided pressures are lower than left-sided pressures in the heart. The right atrial pressure tracing in tricuspid stenosis will show a prominent A wave due to the forceful contraction of the right atrium against the narrow tricuspid valve. This prominent A wave is also reflected onto the jugular venous pulse. It can also produce presystolic hepatic pulsations. Platypnea orthodeoxia has been described in A. Pulmonary arteriovenous malformation, B. Cirrhosis liver, C. Aortic aneurysm, D. All of the above. Correct answer D. All of the above. Platypnea orthodeoxia is characterized by dyspnea and systemic oxygen desaturation on assuming the sitting or standing position. It was originally described by Burchell et al. In 1949. Wrong statement about defibrillation of heart. A. Person lying in water should be moved out before defibrillation. B. Person lying on ice or snow need not be moved out. C. Chest drenched with perspiration should be wiped before defibrillation patches are applied. D. Anteroposterior shocks are not useful. Correct answer D. Anteroposterior shocks are not useful. Defibrillation electrodes should be placed on the bare chest with the electrode marked as sternum, usually in the right infraclavicular region, and the electrode marked as apex in the infralateral left chest, lateral to the left breast. Alternate positioning on the lateral sides of the chest or biaxillary position can also be used. Another method is to keep the left pad in the standard apical position and the right pad on the right or left upper back. If a pacemaker or other implanted medical device is present, the pad should be kept at a minimum of 2.5 cm from the device. Anteroposterior shocks should be considered to minimize the damage to implanted devices whenever feasible. In case an implanted cardioverter device is delivering a shock, as evidenced by muscle contractions similar to that seen during an external shock, one should wait till the device therapy is completed in order not to interfere with it. Defibrillation patches should not be attached over transdermal medication patches, and these should be removed before attaching the patches. If the person is lying in water, he should be moved out before using a defibrillator. But a person lying on snow or ice can be defibrillated. If the chest is drenched with water or perspiration, it should be wiped out before defibrillation pads are applied. Occasionally, unduly thick hair on the chest may require at least partial removal for successful defibrillation. Significant level of apnea-hypopnea index. A. More than 2, B. More than 3, C. More than 4, D. More than 5. Correct answer D. More than 5. Apnea-hypopnea index is the number of episodes during an hour, with each episode lasting more than 10 seconds. An AHI more than 5 is significant. Obstructive sleep apnea is due to the collapse of the pharyngeal airway during sleep. This obstruction could be partial, causing hypopnea, or complete, causing apnea. The pharyngeal airway does not collapse in the awake state due to reflex activation of dilator muscles. This reflex is lost during sleep, but hypercapnia due to the apnea during sleep can stimulate the respiratory drive and cause arousal to activate the reflex. Obstructive sleep apnea is associated with snoring and increased daytime somnolence. Apneic episodes can be associated with severe rise in blood pressure, even up to levels of 240 by 130 millimeters of mercury. This is associated with hypoxia, hypercapnia, and adrenergic activation in obstructive sleep apnea and can promote cardiovascular disease. Heart rate variability is reduced in those with obstructive sleep apnea. There is also release of endothelin, which could be reduced by giving continuous positive airway pressure. Oxidative stress and platelet activation also can occur in obstructive sleep apnea. Systemic inflammation with elevated C-reactive protein and endothelial dysfunction have been thought to be due to repeated episodes of apnea. Cardiac arrhythmias have also been correlated with episodes of obstructive sleep apnea. Apnea and hypoxemia have been thought to initiate bradyarrhythmias by eliciting the dive reflex causing vagal activation. Atrial fibrillation and ventricular premature complexes have been associated. Though there were initial reports of benefit from atrial pacing in sleep apnea, this was not demonstrated in subsequent studies. Other associations due to hypoxia are nocturnal angina, pulmonary hypertension, and renal disease. Paget-Shorter syndrome is A. Compression of the left iliac vein, B. Thrombosis of deep veins of upper limb, C. Thrombosis of deep veins of lower limb, D. Thoracic outlet syndrome. Correct answer B. Thrombosis of the deep veins of the upper limb. Paget-Shorter syndrome is the spontaneous thrombosis of the deep veins of the upper limb, axillary or subclavian. The syndrome was described independently by von Shorter in 1884 and by Paget in 1875. Paget-Shorter syndrome is also known as effort thrombosis because it is often associated with activities involving hyperabduction of the upper limbs. Sudden jerky movements cause the axillary vein to be crushed between the clavicle and the first rib. This can damage the intima of the vein and initiate thrombosis. The syndrome is also associated with thoracic outlet syndrome due to similar compressive reasons. Painful swelling of the limb is an important manifestation of the Paget-Shorter syndrome. The diagnosis is confirmed by compression ultrasonography or venography. Treatment is by thrombolysis and anticoagulation. Surgical options are needed only for those with persistent symptoms of thoracic outlet compression. Important differential diagnoses include lymphangitis, lymphatic obstruction, and intramuscular hemorrhage. Compression of the left iliac vein by the crossing iliac artery at the iliocaval junction is known as May-Turner syndrome. The compression increases the risk of deep vein thrombosis and may cause varicosities in the affected limb and ulcers due to chronic venous stasis. Narrow P waves are seen in A. Sinus rhythm, B. Retrograde activation through lateral pathways, C. Retrograde activation through septal pathways, D. None of the above. Correct answer C. Retrograde activation through septal pathways. P waves are narrower if the activation is from the center of the heart, as in AV and RT, or septal accessory pathways because of simultaneous activation of both atria. Sinus P waves and P waves due to retrograde activation through lateral pathways have broader P waves as there is only sequential activation of atria. Peak P waves in right atrial overload in the absence of associated left atrial overload also appear narrow. This is because of the relatively narrow though normal base of the P wave, which is taller than normal. In right atrial enlargement, the initial component of the P wave is enhanced as the sinus node is situated in the right atrium itself. When the left atrium is not simultaneously enlarged, there is no widening of the P wave beyond the normal limit. But if there is associated left atrial enlargement, as the left atrial activation occurs mostly after the right atrial activation, it is not superimposed on the right atrial activation, resulting in a notched wide P wave in lead 2. The P wave may appear narrow and peaked in presence of tachycardia. This is part of shortening of all intervals with tachycardia, leading to shortening of the P wave duration as well. Narrowing of the base of the P wave with tachycardia makes the P waves sharp and simulate right atrial enlargement. Faults about Dressler beats. A. Seen in ventricular tachycardia. B. Fusion beats. C. Named after William Dressler from Poland. D. Wider than the tachycardia beats. Correct answer D. Wider than the tachycardia beats. Dressler beat, named after William Dressler from Poland, is a fusion beat interrupting ventricular tachycardia. Fusion beats are recognized by narrower QRS complexes than that of the tachycardia. It is the result of fusion of the ventricular tachycardia beat with a supraventricular beat, which could be originating from the sinus node or any other supraventricular focus. The presence of fusion beats, that is Dressler beats, along with capture beats, strongly support the diagnosis of ventricular tachycardia in a wide QRS tachycardia.